The first time it happens, most people dismiss it. A tightness that arrives without warning in the morning, fading before the first cup of coffee. A dull ache that surfaces after an hour at a desk, then vanishes when they stand. A faint pulling sensation during a routine movement, bending to pick something up, reaching for a shelf, that disappears almost as quickly as it came. These moments pass. They always do. And that is precisely why they are so dangerous. The body has a language for damage. It does not always shout. More often it whispers in a register so ordinary, so easily mistaken for fatigue, poor posture, or the residue of an unrestful night, that the signal gets buried beneath the noise of daily life. By the time most people finally sit down in a clinical chair to describe what they have been feeling, they are no longer describing an early warning. They are describing a problem that has been deepening quietly and without interruption for months. What are those early signals? And why, in a condition this widespread, does the window between first symptom and chronic damage close so reliably unnoticed? This is me when I first started medical school. Back then, one of my biggest motivations was my mother. She suffered from a lot of joint pain, especially in her knees and lower back, and seeing that up close left a deep mark on me. That was one of the reasons I decided to focus on this field. I wanted to better understand pain, body movement, and most importantly, find real ways to help people who deal with this kind of discomfort every single day. But after many years in the field, I realized something. Even though I was helping patients and continuing to study, I still wasn't able to reach as many people as I wanted. So I gathered everything I learned throughout my journey into one simple, direct, and accessible guide. But don't get me wrong, this is not some cheap, disposable product made without care. I created this material with real attention to detail, selecting only what I believe is essential to help you take better care of your joints, improve your mobility, and reduce the impact of pain in your daily life. If you struggle with knee pain, lower back pain, or joint discomfort, click the first link in the description and see how this guide can help you take the next step. Don't wait for the pain to get worse before you start taking care of your body. In 2023, the Global Burden of Disease study published its most comprehensive analysis of lower back pain to date in the Lancet Rheumatology. The findings were unambiguous. In 2020, lower back pain affected 619 million people globally, roughly 10% of the entire human population. By 2050, that number is projected to reach 843 million. It is already the leading cause of years lived with disability worldwide, ranking above heart disease, above stroke, above any other condition in terms of lost functional capacity. Despite those numbers, detection remains chronically late. A 2024 study published in the Journal of Pain, tracking community-based adults through the acute phase of lower back pain, found that 32.2% of participants transitioned from acute to chronic pain within just 3 months. Of those who had become chronic at 3 months, 80.6% still had chronic lower back pain at 6 months. Acute becomes chronic. Chronic becomes permanent. The question is not why lower back pain is so prevalent. The question is, what does it say before most people agree to listen? The lumbar spine is not a passive structure. It is a load-bearing architecture of 5 vertebrae, stacked and cushioned by intervertebral discs that absorb pressure, distribute force, and protect the spinal cord from the compressive weight of everything above them. On any given day, sitting at a desk for 6 hours places roughly 2.4 times the body's full standing weight on the L4 to L5 disc, the joint most frequently implicated in chronic lower back conditions. Leaning forward unsupported increases that load further. Reaching for something at ground level without bending the knees can spike disc pressure to levels that, in a compromised structure, exceed the material's capacity to recover. The spine tolerates this. For years, it tolerates this. But tolerance is not immunity. The discs are avascular. They have no direct blood supply. They receive nutrients through diffusion, slowly dependent on movement and compression patterns to function correctly. When those patterns degrade, the disc degrades with them, silently, incrementally, without pain in the early stages because the disc itself has no pain receptors. The damage begins before the symptom, and the symptom, when it arrives, is already behind schedule, which raises a more specific question. What forms does that symptom take in the window before it hardens into something irreversible? The first sign is morning stiffness that lasts more than 30 minutes. Most people experience some degree of lumbar stiffness after sleep. The disc rehydrates overnight, slightly increasing in height, and the surrounding musculature takes time to warm and lengthen. This is normal. What is not normal is stiffness that persists beyond 30 minutes of movement, stiffness that requires deliberate effort to dissipate, that limits range of motion not for seconds, but for half an hour or more. Clinically, that threshold is used to differentiate mechanical adaptation from the early stage inflammation of degenerative disc disease or early ankylosing spondylitis. The second sign is pain that intensifies with prolonged sitting but resolves almost immediately upon standing. This pattern, relief through positional change, is a hallmark of discogenic pain, particularly early stage L4 to L5 or L5 to S1 disc involvement. The disc is under its highest compressive load in a flex-seated position. When the disc's outer fibers, the annulus fibrosus, begin to develop micro tears, the internal pressure it generates under load produces a specific reproducible discomfort. People describe it as a deep heaviness, an interior ache rather than a surface soreness. They stand and it passes, so they assume nothing is wrong. The standing only decompresses the disc temporarily. The micro tears remain. The third sign is intermittent radiation into the buttocks or upper thigh, not the classic leg pain of sciatica, but something subtler. Before nerve root compression becomes severe enough to produce the sharp electrical leg pain most people associate with disc herniation, there is a period of referred discomfort, dull, poorly localized, sometimes felt only during specific movements or after long periods in one position. Patients frequently misattribute this to hip tightness, gluteal muscle fatigue, or unrelated joint pain. It resolves, it returns, it resolves again. This cyclical presentation is not a feature of a minor muscular issue. It is a feature of early nerve root irritation, a structure that, if further compressed, does not recover quickly. The fourth sign is unilateral fatigue in one leg during activities that were previously unremarkable. Climbing a staircase and noticing that one leg tires before the other. Standing for 40 minutes and feeling a heaviness on one side that the other side does not mirror. This asymmetry is a neurological event, not a muscular one. Early compression of the nerve roots serving the lower extremities begins to impair motor signal transmission before pain becomes the dominant symptom. Most people attribute this to being out of shape or favoring one side. In a structurally compromised lumbar spine, it is neither. The fifth sign is pain during or immediately after actions that produce lumbar extension, arching the back, reaching overhead, or lying flat. This is counterintuitive. Most early back pain is associated with flexion-based aggravation. But in the subset of cases involving facet joint degeneration, the small paired joints at the rear of each vertebra that provide stability and guide movement, extension is the provocative direction. The facet joints are compressed by arching, and when their cartilaginous surfaces begin to thin, that compression produces a localized sharp ache that fades within minutes of returning to a neutral or slightly flexed position. It is easy to miss. It is easy to explain away. The same pattern repeats across weeks, across months, and the tissue continues to thin without anything visible from outside the body. The pattern across all 5 of these signs is the same: brief, self-resolving, easily rationalized. Not one of them announces itself as a medical event. Together, they are the scaffolding of a condition in the process of becoming permanent. The answer to why these signs are so easily dismissed is not psychological weakness, it is structural. Pain is not a direct measurement of damage. It is a processed output, an interpretation generated by the central nervous system based on inputs from peripheral nociceptors, filtered through prior experience, threat appraisal, and current biological context. The same degree of tissue damage can produce different pain responses depending on whether the nervous system has been sensitized, whether psychological stress is elevated, whether the individual is fatigued. Consider the analogy of a building undergoing foundation subsidence. The walls crack slowly. The cracks are thin, easy to fill, and easy to ignore. The structure continues to stand. Nothing from the outside suggests that the foundation is shifting until the day it shifts enough to compromise a load-bearing wall, at which point repair becomes reconstruction. The intervertebral disc functions on a similar principle. The outer ring of the disc, the annulus fibrosus, is densely innervated at its outermost layers, but its inner nucleus has almost no pain sensation. Damage migrates from the inside out. By the time the outer annular fibers are sufficiently disrupted to produce consistent pain, the internal structure has typically already been altered for months or years. The 2023 Global Burden of Disease analysis established that 38.8% of the years lived with disability attributable to lower back pain are linked to occupational factors, smoking, and high BMI, all of which degrade disc health progressively without acute events over extended periods. Professor Lorimer Moseley of the University of South Australia, whose 2024 systematic review and meta-analysis published in the Canadian Medical Association Journal tracked recovery across acute, subacute, and persistent lower back pain cohorts, identified the same asymmetry. Most acute episodes recover. But once pain persists beyond a few months, the probability of full recovery decreases substantially. The clinical window is not weeks. It is the first several months of symptom presence, the precise period during which these 5 signs are most likely to be present and most likely to be ignored. The biology does not wait for acknowledgement. Disc dehydration, facet joint degradation, and early muscle inhibition patterns continue on their own timeline, indifferent to whether the individual has decided the symptom is worth investigating. If these 5 signs are identifiable, measurable, and well documented in the clinical literature, why do the majority of people presenting with chronic lower back pain describe years of symptom dismissal before seeking care? The healthcare system is built for declared emergencies, not for gradual accumulations. A person presenting with morning stiffness and a vague, self-resolving hip ache does not, in most clinical contexts, trigger the diagnostic response appropriate to early structural degeneration. Standard imaging, a plain radiography cannot visualize early disc changes. MRI is rarely ordered at the first or second clinical visit in the absence of neurological symptoms. The absence of a visible finding becomes a clinical endorsement of continued watchfulness, which is absorbed by the patient as confirmation that nothing is wrong. There is also a measurement problem. Pain is self-reported. The 5 early signs are intermittent, they come and go. A symptom that has resolved by the time the patient is examined is a symptom that is difficult to document. Absence of the symptom in the examination room is not absence of the symptom in the body. The disc does not reset between appointments. The 2024 cohort study in the Journal of Pain found that 32.2% of participants crossed into chronic lower back pain within 3 months of their first acute episode, and that 80.6% of those who became chronic at 3 months remained chronic at 6 months. The window is not wide. Yet the NIH, as of 2023, had reduced its research funding for back pain from $170 million in 2019 to $69 million, a cut of more than 59%, at the same moment that prevalence projections were reaching their highest recorded levels. The field is under-resourced precisely as the problem scales. The early signs are real. The failure to catch them is structural, systematic, and documented. There is a tightness that arrives without warning in the morning. It fades before the first cup of coffee. A person goes through their day. The symptom does not return. They do not call anyone. Most acute episodes of lower back pain recover. The body has genuine capacity for self-correction in the early phase. That fact is true, and it is also the fact most likely to undermine the only intervention that the early window allows: attention. The 5 signs are not harbingers of guaranteed decline. They are data. They are the body's earliest available language for a structural process that, if acknowledged, leaves options open. If not acknowledged, if absorbed into the background noise of a life that has more pressing demands than a dull ache that will probably go away, they tend, in roughly 1 in 3 cases, to stop going away. The spine does not announce when the window closes. It simply one morning does not open again.